Assalamu alaikum. I'm Dr. Laila Sarwat, lecturer of clinical pathology hematology. I'm going to introduce or present this lecture about leukocyte disorder today instead of Professor Abdullah. First, I would like to tell you about the total white blood cell count that we get all the information about the white blood cell count from automated analyzers, and the differential are usually measured from these automated cell counters. And the white blood cells that we are having from the sheets printed from these analyzers reflect the circulating pool of myeloid and lymphoid cells. The white blood cells, they are presented either in microliters or a cubic millimeter, and we have reporting either in a relative proportion for each type of white blood cells indicated by percentage, or the absolute number, which is the percentage of each type of white blood cells multiplied by the total count of white blood cell count. And in this slide, I just want to show you how we have normal or different normal ranges of the white blood cell count, the different and its differential regarding the polymorph, band, neutrophil, monocyte, eosinophil, and basophil. They are different from different age group, during birth, childhood, and during the first year of life, and in early childhood, and in adults. Every stage of life, they have different normal white blood cell count and differential. And in disease states, for sure, the white blood cell count and its differential, they vary a lot. For example, in bacterial infection, the white blood cell count increase, and they are mainly in the neutrophilic side. In steroid therapy, the white blood cell count increased, and also in the neutrophilic side. After splenectomy, the white count increased. Also, during viral infection, the count either increased or decreased. During chemotherapy, we noticed that the white blood cell count is decreased. And in this slide, I just want to show you the different morphology of the white blood cell count circulating in our peripheral blood. They are either neutrophil, which is the largest, highly banded and highly granular cells that we are having in our peripheral blood. The eosinophil, they have a very characteristic binucleated cell with azerophilic granules, and they have pod orange, or they are either orange like granules. The basophil, they have a characteristic ink bluish dots. They are even in certain cases encroaching over the nucleus, and the nucleus may not be apparent. The monocyte, which is the macrophage system in the peripheral blood, and they have a ground glass appearance, and the nucleus seems like as if it is an active nucleus, and the nucleus may be wrapped or look as if it is wrapped inside the nucleus. And this is a picture, or this is just to show you how the different white blood cells they are looking like under the microscope when we have a stained blood film. Here is the basophil, the neutrophil, the characteristic eosinophil, the monocyte, and here is a band-shaped neutrophil, and this is a lymphocyte in a background with red blood cell. We can classify the leukocyte disorders into a benign or a malignant disorders. The benign disorders, they are either quantitative or qualitative. Quantitative, it means like we have change in the number of the white blood cells. Qualitative, we have a change in either the morphology or the function of these white blood cells. The malignant disorders that we are having, or the most characteristic malignant disorders for the white blood cell, they are either leukemias, either acute lymphoblastic or acute myeloid leukemia, myeloproliferative neoplasm ranging, or for example like CML, polycythemia, essential thrombocythemia, or myelofibrosis, lymphoproliferative disorder, and the most common disorder is CLL, or plasma cell disorders is like multiple myeloma. This is slide just to show you how and where the neutrophil go through the proliferation and the maturation stage. Mainly the proliferation and the maturation stages where or take place in the bone marrow. The proliferation takes about 6 to 7 days, and the maturation take about 6 and 7 days, and the remaining mature forms extravasated to the peripheral circulation. 8% of them are intravascular and 2% of them go through the tissue compartment. The proliferation starts from the early precursors of the myeloid series, which we call it, or what we call it, myeloblast, and then go through the more mature stage, which we call it the promyelocyte, and then to more and more mature stage, we call it myelocyte. And this is the stages or the different stages of granulocyte maturation, ranging from the myeloblastic stage up to the most mature form that we see it in the peripheral circulation of normal person, which we call it the neutrophil or polymorph neutrophil. It has around 3 to 5 lobules and granulated large cytoplasm, and this is the form what we call it a band form. And this is another figure to show you the maturation stage from the metamyelocyte into the band form till the mature stage or to the full mature neutrophil stage. And this slide just to confirm that approximately 10% of the developing neutrophil are in the circulation or marginated or into the tissue. The disorder of neutrophil number. Neutrophil, we have or we give a very great concern to the neutrophil because this is or it constitutes a large percentage of the white blood cells. So the neutrophil number is a very important point that we have to notice in the CBC or the white blood cell reporting when we have a CBC report or automated cell counter report. So the disorder of neutrophil number is either neutrophilia or neutropenia. Neutrophilia when we have a greater number, more than 7,700 cells or neutrophil per microliter, or neutropenia when we have less than 1,500 or 1,500 cells per microliter. And as we know, either if it is neutropenia or neutrophilia, it may be inherited or acquired. The neutrophilia, it means that we have abnormally high absolute neutrophilic count. It may be in the form of shift to the left, just increase in the release of the precursors from the bone marrow, and it may not be necessarily associated with neutrophilia. Acute shift from the marginate neutrophilia may be due to acute shift from marginating to the circulating pool, and this is also may not be associated with increase of the total white blood cell count, and this condition is associated with steroid treatment, exercise, epinephrine, hypoxia, seizures, or other stress. Maybe neutrophilia is resulting from chronic stimulation, excess cytokine to stimulate the proliferative pool, and maybe this is associated, or the causes of this chronic stimulation is infection, Down syndrome, pregnancy, eclampsia, chemotherapy recovery, myeloproliferative disorder, and myelometastasis. So most of the pathogenic causes lie within this category of chronic stimulation, where we have excess cytokine or stimulate the proliferating pool of white blood cells. Neutropenia. When we have too few neutrophils, less than 1500 per microliter, so we have increased, or this kind of patient have increasing the risk of infection. If neutropenia may be categorized into high risk, intermediate risk, or low risk according to the number of neutrophil count. So if we have neutrophil count between 500 to 1000, we have increasing the risk of infection from exposure. But if we have very low neutrophil count below 500, this patient have increased risk of infection from host organism, or in another words, we can call it an opportunistic infection. These patients, they are exposed to more opportunistic infection. The acquired causes of neutropenia may be due to decreased production from the bone marrow, or increased destruction in the peripheral circulation, or shift to marginating pool. It means like we have a lot of neutrophil moving from the circulating pool and attach along the vessel wall. And this happens in severe infection, endotoxin release, hemodialysis, or cardiopulmonary bypass. Increasing the destruction when all the proliferation and maturation stage is within normal pathway, but we have certain things that meet the neutrophil into the peripheral circulation and cause destruction for these cells, especially in autoimmune diseases like rheumatoid arthritis, systemic lupus, and all similar conditions. If we have decreased production, so the factory or the bone marrow itself, it has certain obstacles to help the neutrophil to proliferate and mature, especially in chemotherapy or with certain treatment like antibiotics that have certain effects on the bone marrow. We have another condition we have to know about it, because this is common actually in adolescent or in children, a condition which is called cyclic neutropenia. This patient, they have 20-day cycle of neutropenia, and after this 20 days their neutrophil count may reach normal level. This is actually an inherited disorder, and it's an autosomal dominant disorder. These patients, they are presented with fever, mouth ulcers, and usually they are presented into childhood age and improve after puberty, and they are treated by giving certain granulocyte colony stimulating factors. Back again to congenital neutropenia, this patient may have increasing risk of developing leukemia, so the treatment is either granulocyte colony stimulating factor or bone marrow transplant. Shifting to another cell which is very important in our peripheral circulation is the monocyte. And as I told you, the monocyte is the macrophage system or the reticuloendothelial system of our peripheral blood, and the average count or ranging from 200 to 800 cells per microliter. The disturbance in monocyte is either disturbance in the count or the function, but in count, if we have low count, so may be associated with stress or steroid therapy. Elevated count may be associated or may be caused by malignancy, granulomatous disease, marrow recovery, certain infection like TB, malaria, leishmania, brucella. And next we can go to eosinophil. As I told you, eosinophil, they have a very characteristic morphology, having binucleated and having orange or port orange granules. Conditions associated with increased eosinophilic count, as commonly or as we most of us know, that they are associated with allergy, asthma, parasitic infection. In certain conditions, they may be increased in certain neoplastic disorder like Hodgkin disease, lymphoma, or other tumors, and also in collagen vascular disease or vasculitis. Certain conditions, we have hypereosinophilia, and we don't know the exact cause. We call it idiopathic hypereosinophilic syndrome, and they have elevated eosinophil count associated with certain organ dysfunction like the gastrointestinal system, skin troubles, CNS or cardiovascular disorders. And in this hyper or idiopathic hypereosinophilic state, we have a count of more than 5,000 cells or eosinophil per microliter and require treatment with either immunosuppressive or antihistaminics. Disturbance in the basophil count, they are either with low count in hypersensitivity or steroid therapy, or high count in allergy, infection, endocrinopathies, myeloproliferative disorders, or in systemic mastocytosis, maybe due to excess histamine release. Lymphocytes. In this figure, I wanted just to show you that the lymphocytes, they are the smallest of the white blood cells that we can see or circulate in our peripheral circulation, and they have compact nucleus and very small rim of the cytoplasm. They are originated either from the bone marrow or the thymus, and from secondary organs including the spleen, lymph node, tonsil, pile patches into the gastrointestinal tract. We have three different populations of lymphocytes, either B lymphocytes, T lymphocytes, or NK cells. The T lymphocytes, they are the predominant lymphocytes in our circulating blood, followed by the B lymphocytes and NK cells. We have to differentiate from the hematological point of view, or when we have a slide under the microscope or a peripheral blood, between normal lymphocyte and reactive lymphocyte, because this is a very important if we have to put a comment on a lymphocyte. Is this a reactive lymphocyte or just normal lymphocytes? The normal lymphocytes, they have a smaller size between 8 to 12 microliter or micron. The reactive is a slight or a little bit larger. The nuclear cytoplasmic ratio, they are very high or high into the normal lymphocyte, and they are decreased when we have a reactive lymphocyte. The cytoplasm in normal lymphocyte is very scanty, as we see here in this figure, and maybe is either colorless because it's a scanty cytoplasm to very light blue. In the reactive lymphocyte, we have abundant cytoplasm. It may be colorless to dark blue, or maybe in certain conditions have azerophilic granules and can scallop the RBCs, like in this figure. Scallop, like it can be larger and overlay the red blood cells. The nucleus into the normal lymphocytes, they are small, rounded, compacted nucleus, and in reactive, they are elongated and irregular, as we see here. The chromatin into the normal lymph, they are coarse and compact. In reactive lymph, they are coarse to moderately fine, as we see here. The nucleoli, we don't have either any nuclei into the normal lymphocyte, and it is the same for reactive, or maybe it's a very little apparent into reactive lymph. The lymphocyte disorders, it is important to differentiate between benign condition associated with lymphocytosis from malignant lymphoproliferative disorders. How we can do this? We can see the peripheral blood film under the microscope, and we can see, or we can identify, if we have a heterogeneous reactive lymph, and we can confirm what we are seeing by adding more serological tests for antibody against infectious agents. And we have to re-evaluate the whole CBC report about any anemias or thrombocytopenias, and if we have all the above conditions or all the above items positive, so we are in favor of benign diagnosis. As I told you before, if we have any disorder, so we have either quantitative or qualitative disorders. In lymphocytosis, we have excess lymphocyte in blood, and the absolute lymphocyte count is increasing, or more than 4.5 or 4,500 cells per microliter in adult, and the relative count may be increased more than 45%. It is a self-limited condition, mostly associated with infections. Reactive process, as usually we see, is due to infection or inflammatory condition. B and T cells are involved. The lymphocytes develop in response to antigenic stimulation, so they become activated. The causes of reactive lymphocytosis, it is of the most important things that we have to know. It is either Epstein-Barr virus, cytomegalovirus, or something. But infection with Epstein-Barr virus release a state or a condition that we call it infectious mononucleosis. It's a very important to know that the clinical symptoms of infectious mononucleosis is we have a triad of fever, pharyngitis, lymphadenopathy. The patient suffers from dysphagia or difficult swallowing, general malaise, fatigue, and the spleen is enlarged and the lymph nodes are firm but not tender or warm. It is generally, this condition is seen in children and young adults between 14 to 24 years old. The CBC in infectious mononucleosis condition, we have relative or absolute lymphocytosis. The peak is between 2 to 3 weeks of infection and remain elevated for 2 to 8 weeks. The leukocyte count is increased, ranging from 12,000 to 25,000 per microliter. In the peripheral smear, the reactive lymph, as the table, we can differentiate between the normal and the reactive lymph. We have special criteria or specific criteria for the lymphocyte or reactive lymph in infectious mononucleosis. They have irregular cytoplasmic borders with increased cytoplasm and dark blue edges around the periphery of the cytoplasm, as we see here in this figure, and we call it downy cell. More than 20% of the peripheral lymphocytes are reactive lymph, and we have to confirm this condition by having heterophile antibody test, or what we call it monospot test. Other causes of reactive lymphocytosis is either toxoplasmosis, acquired infection in children and adults due to ingestion of oocytes from cat feces or undercooked meat, and can be transmitted via placenta. That's why we are screening for toxoplasma in patients or females with recurrent abortion. Other cause for reactive lymphocytosis is cytomegalovirus, and this belongs to herpes family. It's endemic and acquired through transfusion, sexual contact, or close contact, and can be also transmitted across the placenta. And it has a very poor prognosis in immunocompromised individual who contact virus. Other infectious lymphocytosis, actually the children are more vulnerable to viral infection because this virus may be including adenovirus, Coxsackie, or Bordetella pertussis. The leukocytosis and lymphocytosis occur in the first week of illness and then return to normal. That's why in children or childhood age, most of the children, we can see that lymphocyte a little bit increase and maybe more a little bit or equal to the number or the percentage of neutrophil, and we have to screen by doing peripheral blood film and confirm that the morphology of these lymphocytes are either reactive or not alarming for any other disease. Lymphocytopenia, it means like we have decrease into the lymphocyte or the absolute lymphocytic count below 1000 per microliter, maybe due to decreased production or increasing the destruction of lymphocyte, or changes in the lymphocyte circulation pattern, or may be associated with corticosteroid or steroid therapy. Going to the malignant leukocytic disorder, the most common cause of malignant leukocytic disorder is acute leukemia, and as I told you in the early beginning of the classification of malignant disorder, it may be either acute lymphoblastic or acute myeloid leukemia. The acute lymphoblastic leukemia is more common in children, and it's for their good luck it's a curable one, and in male is more than female. In AML, it is mainly present in adult and male more than female, and it's a little bit aggressive than acute lymphoblastic leukemia, and it's curable in minor or in a little percentage of adult. The laboratory diagnosis of acute leukemia, mostly it is suspected from patient doing CBC. We don't have abnormality into the white blood cell count only. Maybe the whole CBC is affected, so the patient may be presented with decreased hemoglobin level, normocytic normochromic anemia, thrombocytopenia, and the white blood cell count may be presented with either very low count up to very high count, so ranging from about 1000 or even 500 total white blood cell count up to 200,000 per microliter. And when we do a peripheral film, we can see the circulating blast in the peripheral blood. And this is just to show you how the acute lymphoblastic leukemia is looking like and how the acute myeloid leukemia is looking. As you see, the normal lymphocytes, they are very, very smaller than the neutrophil or the myeloid series. That the same will happen for the blast cell. The lymphoblast, they are a little bit smaller than the myeloblast. Again, the lymphoblast will look smaller than the myeloblast. The cytoplasm in the lymphoblast will be very scanty. In the myeloblast, they are moderate. The chromatin in the lymphoblast a little bit dense, but for the myeloblast, they are fine. The nuclei may be indistinct, especially in ALL1. In myeloblasts, they are prominent nucleoli. We cannot see an hour rows or any granulation into the cytoplasm of the lymphoblast, but in myeloblasts we can see granulation or hour rows, which is very, very characteristic for the myeloblast. Once we have a suspicious of circulating blast into the peripheral blood, we have to do aspirate and biopsy to confirm that we are facing or that we have a case of acute leukemia. And if we have a blast count into the bone marrow more than 20%, so it's for sure a case of acute leukemia, and we have to proceed to do more sophisticated investigation like cytochemical staining. From its name, it's a cytochemical, so it's like an investigation related to the chemical reaction that happens due to granules into the cytoplasm of the white blood cells. So, for example, of this cytochemical reaction or cytochemical staining is the MPO, which stands for the myeloperoxidase, and usually we can use it to identify the acute myeloid leukemia. Non-specific erythrace to identify the monoblast species, which is a subtype of acute myeloid leukemia. Periodic acid Chef, which is P-acetylcysteine, which we can use to differentiate acute lymphoblastic leukemia. Acid phosphatase to identify the TALL subtype. Another sophisticated and more advanced identification or investigation for acute leukemia is immunophenotyping, which depends on the cell surface receptors, or what we call it cluster differentiation, which are the antigen or the that are presented onto the surface of the blood cells or immature precursors that are circulating in the peripheral blood or even um, infiltrate the bone marrow. And by identifying these surface receptors or antigen presented on the blood cell, we can identify if it is acute lymphoblastic leukemia, and the subtype of this acute lymphoblastic leukemia is this of T type or B type, and also it is the same for acute myeloid leukemia. We can identify if it is acute myeloid or not, and subtyping the different type of myeloblast. And to identify this surface receptor, we can use monoclonal antibodies, and the most characteristic or the most common characteristic antibody that we can use for acute myeloid leukemia are MPO, CD13, CD33, and CD117. For BLL, we can use CD10, 19, and 22, and TLL, we can use CD3 and cytoplasmic CD3 and CD7. One other category or another category of malignant uh, abnormality in leukocytic disorder is the myeloproliferative neoplasm. From its name, it's a myeloproliferative, so it is a myeloid cell proliferation. Myeloid cell proliferation, it means like it is either increase into the red blood cell count or the white, the white blood cell count, or uh, high count into the platelet count, or either myelofibrosis. This is all this category is lying under the main title which is called myeloproliferative neoplasm. The WHO every other year is updating itself or updating according to the criteria to identify this myeloproliferative neoplasm and to classify it. And for example, for each type of this myeloproliferative neoplasm, in order to say that we are having a case of myeloproliferative neoplasm and its subtype, we have to have major and minor criteria. For example, if we are having a case of polycythemia vera, we are, or the WHO say that we have to have three major criteria, or the first two major and one minor criteria. One of the major criteria of polycythemia vera is having a hemoglobin more than 16.5 for male and 16 gram for female, or a hematocrit more than 49% in men and more than 48% in women, or increase the red blood cell mass, having a biopsy showing hypercellularity for age with tri-lineage growth, it means like a panmyelosis, presence of certain mutation like JAK2 mutation either in exon 14 or 12, and having certain minor criteria like low level of erythropoietin and something like that. So every other year, the WHO is updating itself to more and more characterize each of these subcategories of myeloproliferative neoplasm. and we have to apply all of this WHO criteria for myelofibrosis and for essential thrombocythemia and for CML. But we have to stop here for CML because CML is a very critical case because you can face it, you can find it anywhere. It may be presented just for you in a CBC, like we have a patient presented with a very high white blood cell count, and this patient may be a CML or a chronic myeloid leukemia case. So we have to identify the laboratory feature for this condition. Usually the patient is presented with normocytic normochromic anemia, very high leukocytosis or very high white blood cell count, ranging from or increasing more than 25,000, maybe reaching 100,000. The differential show granulocytes in all stages of maturation. The basophil stage, eosinophil, and the platelet is either normal or increased or even low. This figure just shows you the peripheral blood of a CML case. As you see here, the patient is having myelocytes, metamyelocytes, neutrophil, basophil. So all different maturation stages of myeloid series are presented into the peripheral blood of a CML case, in addition to basophil and eosinophil. If we have a suspected case of a chronic myeloid leukemia, we have to do more investigation by doing bone marrow examination. Usually the bone marrow is hypercellular. The myeloid erythroid ratio is very, very high. The normal is 2:1, increasing the myeloid ratio up to in relation to the erythroid ratio, reaching up to 30:1. The myelocyte is the predominant cell. The blood cells is less than 10%. The megakaryocytes are increased and dysplastic, and we can see increase in the reticular fibrosis in 30 to 40% of cases. To the differential diagnosis of chronic myeloid leukemia. One of the important and disturbing or confusing condition that we can be confused with chronic myeloid leukemia is a condition that we call it leukocyte reaction. Leukocyte reaction, we have also increase in the white blood cell count, but when we do a peripheral blood film, we see many band metamyelocytes and myelocytes are also seen in the peripheral blood, and we can see occasional promyelocytes and myeloblast may be also seen. This condition is very confusing with chronic myeloid leukemia and can be differentiated from it by doing certain more investigation. We have to do what we call it leukocyte alkaline phosphatase score, which we call it lab score. We can do more sophisticated investigation like doing cytogenetic examination of Philadelphia chromosome, which is positive in CML and negative in leukocyte reaction. And follow up of the patient, we can see that leukocyte reaction is a condition, a transient condition, but in CML patient is not. So the laboratory diagnostic criteria for chronic myeloid leukemia case, this patient is presented with leukocytosis between 50,000 or 50K up to 500,000 cells per microliter, a complete spectrum of all myeloid series in different maturation stage can infiltrate the peripheral blood. Eosinophilia and basophilia is very, very characteristic for chronic myeloid leukemia. The patient is presented also with normocytic normochromic anemia. The hemoglobin level is low, but MCV and MCH are within normal range. The platelet count may be normal, low, or high. Very low leukocyte alkaline phosphatase in comparison to the very high score for leucomoid reaction, and for the Philadelphia chromosome, it is positive in CML case and negative for leucomoid reaction case. Going to this slide and see that for leukocyte alkaline phosphatase, as I told you, it's a cytochemical, it's one of the cytochemical reactions that we can see the reaction within the neutrophil, how it look like. So we have to do the steps for this cytochemical reaction, and we have to rate the neutrophil or the white blood cells, how they are looking like. The neutrophils are rated from 0 to 4 on the basis of the quantity and intensity of precipitated red dye in their cytoplasm. And the sum of rating of 100 cells in the lab score and the cell rating and the total scores are reported. Normally we have the lab score is between 13 to 130, and this is the normal lab score that we have to check for it. Okay. Another condition or another malignant condition associated with increase or very high level of lymphocytes into the peripheral blood and the bone marrow is chronic lymphocytic leukemia. Lymphocytosis, a peripheral blood lymphocytic count is greater than 5,000 per microliter. The lymphocytes are looking mature and small. On immunophenotypic examination or investigation, we can identify these B cells with a specific differentiating antigen, which is completely different from normal lymphocytes. They are expressing B cell marker in addition to CD5, which is not normally expressed on B lymphocytes. On bone marrow examination, we show that the bone marrow aspirates shows greater than 30% lymphocytic infiltration, which is not common in normal bone marrow aspirates. The differential diagnosis of a case of CLL is infectious causes, either viral or bacterial, other malignant causes like leukemic phase of non-Hodgkin lymphoma, prolymphocytic leukemia, hairy cell leukemia, Waldenström macroglobulinemia, large granular lymphocytic leukemia, and we can identify this subcategory of different malignant conditions by doing more and more investigation using immunophenotypic and immunophenotypic examination and immunochemical stain. Another disorder that is associated with abnormal leukocytic count and abnormal morphology is plasma cell disorder. The most common example of plasma cell disorder is multiple myeloma, and we have major and minor criteria to diagnose a case of multiple myeloma. The major criteria is plasmacytoma on tissue biopsy, bone marrow plasma cell more than 30%, monoclonal M spike in electrophoresis, having a high immunoglobulin G more than 3.5 gram per dl, immunoglobulin A more than 2 gram per dl, light chain either kappa or lambda more than 1 gram per dl in 24-hour urine sample. The minor criteria including plasma cell in the bone marrow between 10 to 30%, M spike less than the above recorded levels, and lytic bone lesion, normal IgM, IgA, and IgG levels. In this figure, just to show you that in normal protein electrophoresis, albumin constitutes the major protein of our protein or circulating protein levels in our plasma or serum. But in patients with multiple myeloma, we have here a spike at the gamma region, which very, very characteristic to a case of multiple myeloma. So if we compare here, we have like a broad band, but here we have a very identified spike or band in the gamma region, which is not normal. It's actually looking like the albumin band So this is completely abnormal and very characteristic for multiple myeloma case. This is how the plasma cell in the bone marrow of a patient with multiple myeloma are looking like. They have the characteristic cartwheel appearance, and they have eccentric nucleus and deep basophilic cytoplasm and loss of perinuclear halo, which is characteristic for abnormal plasma cells. Thank you, and sorry if anything is not clear for you, and if we have any question, please don't hesitate to ask. Thank you.